So there's one last thing I want to talk about before we end this segment, and that's B47, which had a great idea. We saw subset analysis of B31 that there were patients who apparently had a HER2 that was 1+ or 2+, or a ratio less than 1.8, that had benefit to adjuvant trastuzumab. So they actually, because that was a unplanned subset analysis, a retrospective, as we were talking about, they went ahead in B47 and did a very large randomized trial, of women receiving standard of care with HER2 1+, and all they think all and 2+, all the way up to, I think, then you could have a ratio of less than 2, I think is what they did. 2 was their cutoff. And they gave them chemo with or without traz. And as we all know, there was no benefit. What do you think guys think of that trial?
I think you can learn things from negative trials.
You can, very much so.
So actually, I was actually happy about that result because it would have rocked my world if we thought that we knew the target, we had a test to identify the target, and then we didn't.
Yes.
That would really set back a lot of precision medicine. So I actually think that's very positive. We understand that. I think also that probably there's been refinements in both local and central technology about testing HER2 from the time of B31 and 9831.
So you think that's the reason why they had the target issue?
Yeah, I think it was a technical issue about that. And I also think that the important thing to use B47 for is what happened to those patients. 90% 5-year disease-free survival.
Which is incredible.
Which is incredible. So that's the number. And they were mostly ER positive, but there was a third or so that were triple negative.
So that's the criticism of that trial.
They were mostly ER positive.
They're mostly ER positive. They were doing well no matter what you put them on.
Also, Shireen Loy has shown that if you have low level, low ratio, and 2.2 up to I think 3.2 or so, that the benefit from trastuzumab is definitely muted. So you still see a benefit, but it's much less. So it makes sense, actually, that as you keep going down, but that data, of course, way post-dated the development of B47 and even came out after accrual had been finished. So, it made a lot of sense to us. And I think it's what we see in the neoadjuvant setting. The ER positives with low ratios don't respond as well.
Speaking of ratio, do you use copy number or ratio? Copy number or ratio for HER2?
We use both.
Same thing? Which do you use more?
The ratio.
Ratio.
Use ratio, not copy number.
No, but if you have a copy number over 6.
Everybody, what happens if the copy number is 4 and the ratio is 1.5?
They're negative.
It has to be over 4.
Per ASCO guidelines. So we're all comfortable
amplified,
with that.
yes.
Because people are asking that question. This is a big question, as you know, in clinical practice. Which one do you use?
They think they're
None
indeterminate,
of the
but they're
trials
not
had
amplified.
eligibility criteria of just the copy number to call them positive, and I think that's been a bigger issue. And I think we're probably expecting updated guidelines yet again for the HER2 testing, and we'll see if this is further clarified or not in that updated guidelines.
But it will still say copy number over 6, and I think the issue is the indeterminate will maybe be a little bit clearer as opposed to muddy. But these patients who have a ratio of 1.5 and a copy number that's between, like 4.2, they are not amplified.
Talking about HER2 negative and, taking a tangential approach here, in the metastatic setting, what was very intriguing was an antibody-drug conjugate trial for HER2 low expressors, which despite having activity not only in the HER2 expressors, also had activity in the HER2 low expressors from the Daiichi compound, the antibody-drug conjugate.
We're going to get to that in the next section.